If you ever wondered what's really inside the breast, so today we're discussing the breast. We're going to uncover its hidden structures, the blood vessels, the nerves, and why the breast is so important in clinical medicine. Hi, my name is Dr. Kenny. Welcome back to Neurosketch. But if this is the first time you've seen this channel, then subscribing is the great way of keeping in touch, the great way of keeping videos popping out to you. Okay, guys, and like the breast is what places us in class mammalian. So what's so mammalian about us is the presence of the breast. So the breast, we have been grouped in mammalian group because of presence of the breast. And so the breast is important for production of milk, and so because they produce milk, they are accessory glands of reproduction in females. In male, the breast is rudimentary and functionless. This is because the development of the breast, mainly rely on the hormone estrogen. So if you don't have the estrogen, or the estrogen level is very low, it's hard for you to develop the breast. It's hard for you to develop the breast. So both male and female have got the breast, but the breast develops in females because of the presence of the female this female sex hormone, which is known as estrogen, and it's rudimentary in male because we don't have sufficient amount of estrogen to develop breast. So the breast is almost hemispherical. It's like half a sphere, and it spans from the lateral border of the sternum all the way to the mid-axillary line, say on the horizontal extent. But it spans from the second ribs to the sixth rib. As you might have seen, guys, the lower pole of the breast is fuller. As compared to the upper pole, and this is due to the effect of gravities. So the gravity is pulling downward here, and so the lower pole of the breast is fuller than the upper pole. Okay. So the breast is sitting on this muscle. Remember what is this muscle? It says that is the pectoralis major muscle, and the pectoralis major muscle forms a bigger part of the base of the breast. So almost maybe the bigger part of the breast is resting on the pectoralis major, but we still have a part that is extending to this muscle. We call this muscle the serratus anterior. But remember, the serratus anterior muscle was interdigitating with the external oblique muscle. So together all these muscles, they form like the base of the breast. So the breast usually weighs about 500 gram to 1 kilogram, or to 1,000 grams. And this depends on a number of factors, not to mention genetics. So the genetic makeup will also determine your size of the breast, but some other factors like estrogen, the pregnancy state. Someone is pregnant, the breast become a little bit bigger and heavier, and so and menopause will have a lot of factors that may intervene to determine the size of the breast. The size of the breast, as we shall see. Okay, so the breast has got a prominent which is known as the nipple, and then the nipple is surrounded by a circular area which is a little bit darker, which is known as areola. So the areola has got some glands that will secrete a sebum-like material that will help to lubricate the breast during the breastfeeding. Because what is so important about the breast is breastfeeding, and what places you in mammalian group is the ability to breastfeed. Okay, guys. So let's see. We have. So this is the breast. And the breast has got extension toward the axilla. It has got extension. We have a part of breast tissue that is extending toward the axilla, and we call it a tail. But we call it a tail of the tail of Spence, the axillary tail, or the tail of Spence. So this is actually the breast tissue that extends towards the axilla. So it's like it has everything like any other breast tissue. Okay. So so whatever changes are happening in the breast tissue, they also happen to the axillary of Spence. So some ladies, they discover this part of the breast during menstruation, because you also will have changes, breast changes during menstruation. So some people may think they have something like a lump or like a tumor within the breast, because it feels like lumpy or bumpy, like during the menstruation, I mean along the menstrual cycle. So they might think that have this the tumors or whatever within, but that's actually the breast tissue. So whatever is happening to the breast here can happen also to the axillary tail of Spence. So it's like extending, so it's like, extending somewhere to find its own shelter. It's like you're moving from your home to your ghetto, okay? So that's the axillary tail of Spence. So but you're still the family, you're still the part of the family, but you're moving to ghetto, okay? Yeah, so we have a space behind the breast, which is known as the retromammary space. So this is potential space, and it's being fed by the adipose tissue, and so it brings like mobility of the breast. But it can also be filled with some blood or some other material during pathological changes in the breast. Okay, so the breast has been made by two kinds of tissues. So we have the glandular tissue, the glands, the glandular tissue, and the fatty tissue. How many kinds of tissue, guys? Two kinds of tissue. The glands, the glandular tissue, and the fatty tissue. And deep within the fatty tissue, we have the ligaments that suspend the breast. So we call the suspensory ligaments, or we're gonna say the ligaments of Cooper, or the Cooper's ligament. That's a suspend the breast and hold the breast in space, in a place. Okay, guys, how many kinds of tissues we have? We have the glandular tissue and the fatty tissue, but the ratio of the glands to fatty tissue, it changes depending on different circumstances. But the main factor being the estrogen and the age, and we will see what are the changes, what happens as you're exposed to different levels of estrogen, and you're changing with age. Okay, so this is the mammary glands. These are the mammary glands. Why mammary? Because these are what produces milk. Okay? So these are the what produce milk. So the milk is produced by the mammary glands, and so the mammary glands, they are dilated from the lobules. So these are the lobules of the mammary gland, but the lobules are being connected, are being drained by the lactiferous duct. So this we call the lactiferous duct. But at certain point, the lactiferous duct will dilate to form the lactiferous sinus, and these sinuses they will empty to the nipple. So they are actually like the temporary storage of milk, just waiting for the baby to suck. And maybe we learn in physiology that the act of sucking, the baby is not actually sucking, so it's like the milk which is coming down, and we have that mechanism called the let down effect, or let down mechanism of production of milk. So we have like 15 to 20 lactiferous ducts that are emptying to the nipple. 15 to 20 lactiferous ducts that empty into the nipple. So these mammary glands, they are actually modified sweat glands. So they are modified sweat glands. And they are being grouped into the apocrine glands. So what are the apocrine glands? The apocrine glands are those glands in which the secretion of the gland contains a part of the cells. Okay, part of the cell. This is to say, the milk, which is secretion in this case, the milk will contain the apical cell. So we're producing milk, and it will contain the apical cell, and this is what we call the apocrine glands. Okay, guys, we said we have the ligament that they support the breast and they hold the breast in space. What is the name of the ligament? We say we call them the Cooper's ligament or the suspensory ligament. The Cooper's ligament or the suspensory ligament. We said the breast is being made by two kinds of tissues. Number one is glandular tissue. The glands, as you can see, these are the glandular tissue. but the second thing is the fatty tissue. And then deep within fatty tissue, we have the ligaments. We have the ligaments that support the breast and they keep the breast in place. So actually, when these ligaments when they become stretched, because what is the function of the suspensory ligaments, the ligaments of Cooper's, is to hold the breast in space. So what happens if they are stretched? So the breast becomes ptotic or drooping. So it drops down and becomes pendulous. Also, we have a number of reasons why someone can get the ptotic. But basically it's the stretching of the Cooper's ligament. Okay, so the breast can be divided into 4 quadrants, into 4 parts, and this is for the clinical purpose of description of the masses of the breast mass. Okay, so if you are drawing the line, the vertical line through the nipple, the breast can be divided into inner and outer half. But also, if I'm drawing another horizontal line through the nipple, the breast can also be divided into the upper part and the lower part. So we have the upper half and lower half, but we can have the inner half and the outer half. So these 2 lines, they divide the breast into 4 quadrants. So we have the upper outer quadrant, the upper inner quadrant, the lower outer quadrant, and the lower inner quadrant. But someone can say it is upper lateral quadrant, upper medial quadrant, lower lateral quadrant, lower medial quadrant. It's all accepted. So this is for the description of breast mass. So someone can say, I found hard mass on the medial, on the upper inner quadrant of the right breast, or the upper inner quadrant of the left breast, for description of different pathology of the breast. Okay, here we go. Now we are going to the blood supply of the skin of the breast, and we are starting with arterial supply. So almost 60% of the blood supply of the breast, they are coming from the internal mammary artery. So we have an artery here which we call the internal mammary artery, or the so-called the internal thoracic artery. This is the first part of the subclavian artery. We are not discussing it here in detail. We're going to discuss it when we're doing thoracic cage, as I told you the other time. So it's coming from the first part of the subclavian artery, and it supplies by bigger percent the breast in other arteries. But we have the axillary artery. And the posterior intercostal arteries. Guys, from the internal mammary artery, so this is the internal mammary artery, or the so-called the internal thoracic artery, we have got the perforating branches. From the intercostal arteries, anterior intercostal. What are the anterior intercostal? The anterior intercostal, they are branches of the internal mammary artery, as we shall see sometimes later. So they form the perforating branches, and this perforating branch, because they supply the medial side of the breast, we call them the medial mammary branches. Okay, and then from axillary artery, we had the thoracoacromial artery that was supplying this upper part of the breast. It's cut here, but we can all see it it was coming from the second part of the axillary artery, and it was supplying that part. But we also saw the lateral thoracic. So we also saw the lateral thoracic artery, and I told you the lateral thoracic artery, the main contribution to the lateral side of the breast, because it was running along the lateral margin of the pectoralis minor muscle to supply the muscles underneath the serratus anterior and some other muscles of the pectoral region. But it also gives a branch to supply the lateral part of the breast, and so it is the branches that are known as the lateral mammary branches. The lateral mammary branch, we have the lateral mammary branch from the lateral thoracic artery, but we have the medial mammary branches from the the internal mammary artery. But we also have the thoracodorsal artery, which is coming from the subscapular artery. Remember the discussion of axillary artery. So the thoracodorsal artery is also contributing to part of the supply to the breast. But from the posterior intercostal, we saw the posterior intercostal arteries. So they also give the lateral cutaneous branches. So they give the lateral cutaneous branches, the terminal branches of the intercostal perforators. We saw them the other time. So they are supplying. Guys, if you go and watch the part on the pectoral region and the vessels, the neurovascular structure of the pectoral region, you have to watch before you watch this one. Okay, so these they are also forming part of the lateral supply of the breast. So they have the mammary. We have the lateral mammary branches from the posterior intercostal arteries, but we also have lateral mammary branches from the lateral thoracic artery. So what about veins? So veins, they're almost like they are the same. They bear the same names. So you see, we have the perforating branch of the internal thoracic vein. So what changes is actually the name vein, but almost everything, like they correspond to the arteries. Okay, what is so important clinically about the breast is the drainage of the breast. So the lymphatic drainage of the breast is very, very important, clinically important, because we have some pathologies like breast cancer that are being manipulated by the lymphatic drainage. Okay guys, this is the breast. So the breast has got maybe potentially 2 or 3 important lymphatic pathways, lymphatic drainage. So in 75% of time, the breast will be drained by the axillary lymph nodes. Guys, remember we discussed the axillary lymph node somewhere else, and so we say we'll have the anterior lymph node or the pectoral lymph node. So the pectoral lymph node will actually drain the breast, and so after draining it will draining from the breast into the apical node, and then the apical node is drained to the central node, and the fluid goes. So in 75% of time, the breast will be drained by the axillary lymphatic node, and then in 7%, in 5%, the breast will be drained to the internal mammary lymphatic nodes. We have the internal mammary lymphatic nodes. They are lining along the internal mammary arteries and vein, but a part of breast tissue, but part of lymphatic drainage will go to the abdominal lymphatic nodes. Okay guys, 75% by the axillary nodes, but 5% by internal mammary vein nodes, and then the 25% of times will be drained between the two, between the internal mammary and the axillary lymphatics. So this is to say, the axillary lymph node makes the major contribution of lymphatic drainage of the breast. So if you have blocking of the axillary lymphatic node, we're going to affect the breast at a greater percent. So this is how it is draining, so from 75% to the pectoral to the apical to the central, and central to the apical, and then the cycle goes. Okay, so as we have said, we're going to discuss the nerves and then see the clinical correlates. Okay, so the breast is been receiving the cutaneous sensation, the sensory innervation cutaneous, from the third through the fifth intercostal nerves, the branches of the third through the fifth intercostal nerves, and then it can also get a supply from the cervical plexus. But what is so important to note that at the level of the nipple, the dermatome along the level of the nipple is being supplied by the laterocutaneous T4. The nipple is at the level of T4. This is what is important clinically. They usually ask. You'll be asking your exam about the level of the nipple. Okay, so what are the breast changes? Okay, guys, we have said we have said the breast changes is been it's been contributed by the estrogen, okay, the female hormone estrogen. The estrogen is the major determinant of development of the breast. So the baby is born without the breast tissue. Okay, so we actually have we actually have like maybe the sign, maybe the nipple is there, the nipple and the areola complex, but not like the real breast, the glandular tissue. The glandular tissue are not found. And the glandular tissue, they start to develop during puberty. So at the age of 8 to 15 years of age is where we have like breast development. And what is happening is that due to during puberty we have like increased level of estrogen, and then this estrogen will help to develop the glandular tissue. So we leading to development of the glandular tissue, but also the fatty tissue also increases. So we have like we had a fat pad which was present, just covered. We had the nipples just made up of the breast tissue, of the fatty tissue underneath. And then during puberty, now we start developing the glands. The glands are developing due to what, guys? Due to the hormone estrogen, the estrogen hormone. But you see, we increase in the glandular tissue, but the fatty tissue also increases in a greater percent, like remarkably increasing. Okay, so along the years, this is what is happening. Like we are changing from this to this breast. So what is so important to bring the changes? The hormone estrogen, the estrogen. Okay. But also you can see we have like maybe small the nipple areola complex, the nipple and the areola, but with the time you see the nipple and areola, they also like enlarge. So they also enlarge with time, with time. And then these changes, which these okay, we see sometimes later how they change. Okay, so changing from here to here, but you see sometimes the breast can become pendulous, as we have said, and we see why also the ligaments they become stretched. So what happens during menstruation? So in menstruation, in most females, the breast will enlarge during menstruation, during the menstrual period. And this is due to the increase in levels of follicle stimulating hormone, FSH, and the luteinizing hormone on the glandular tissue. Okay, and so what are the changes that they see? The breast becomes fuller, tender, painful to touch, and then they can potentially become bumpy or lumpy in a cobblestone-like feel, particularly in outer areas. And this is what I told you in the axillary of Spence. Some ladies, they discover like, okay, I have something like a bump. Maybe it's a tumor, maybe it's a cancer or something. It's because that is also a breast tissue that is extending towards the axilla. So the estrogen also increase early in cycle, which causes like the breast duct to grow. But the hormone progesterone level, it will later peak before menstruation, leading to the growth of milk, or the milk glands, which you call the mammary glands. Okay, so clinically important thing about today's discussion is the breast cancer. Like this is maybe the hallmark of having all this discussion. Okay, so in breast cancer, we know that the 75% of times the breast will be drained. The lymphatic fluid will be drained by the axillary lymph nodes. It will be emptied to the axillary lymph node. So in the breast cancer, we can have the cancer cells. That they migrate into the lymphatic, the axillary lymph nodes, and so they may block. They may block the lymphatic drainage. So once the lymphatic drainage is blocked on the axillary part, we know that the axillary part makes a greater part of the drainage. So the breast will become like it will swell. It will swell because it will be full of fluid, and this is what we call the lymphatic edema. Lymphatic edema. The breast becomes edematous. Okay, so we have a blockage. The breast becomes fuller, becomes fuller. So it's full of fluid, but the ligaments might not stretch. So we have the characteristic dimpling of the skin of the breast, and this is called the peau d'orange in French, which translates to the peeling the skin of the skin of orange, the skin of an orange. Okay, why? So you get it. Like, we have the breast is full of fluid, but the ligaments are pulling the breast towards the wall, and so we have the characteristic dimpling of the skin of the breast. Why? Because the breast is edematous, the ligaments are pulling, so they are creating this dimpling. So this is also a dimpling that can happen maybe on one side, on the other side, and then we can also have abnormal contour, like you have a mass, maybe a mass is some, you see, like the breast was supposed to be hemispherical, as we discussed, like half a sphere, but if you see like the contour is distorted, then you know in the back of your mind, like you have something that's going on downside, inside the breast. But also the nipple can also be retracted. So the nipple can also be retracted, and so we call the retracted nipple one among the few features of the breast cancers. What's so important is the lymphatic drainage. 75% goes to the axillary lymph nodes, and so if we have like a blockage here, so the breast will be full of fluid, so it will swell and become bigger. Why? Because of the fluid. But we know the cancer cells, they might spread to the axillary nodes. And this is why when someone is being suspected of the breast cancer, they are undergoing mastectomy. They are removing the breast tissue, the whole breast. They also do the axillary lymph node dissection. Why lymph node dissection? Because 75% of this breast was being drained by the axillary lymph node. So if we don't remove the axillary lymph nodes, we might have the chances that the cancer cells migrated to the axillary lymph nodes. Okay, axillary lymph nodes. And in the two previous videos, I told you when they are doing the axillary lymph node dissection, they are removing this. There are some nerves that can be injured, not to mention the intercostal brachial nerve and the long thoracic nerve. Okay, next to it is mammography, and the mammography is the X-ray of the breast. So why would someone do the X-ray of the breast? So the mammography is done to detect cancerous changes earlier before they become clinically evident. So before they become palpable, so they are detected earlier on mammography to maximize the chances of survival. Because we know most of the cancers can be cured. Most of them can be cured when they are detected earlier. So mammography helps to detect the malignant changes of the breast before the tumors become clinically evident. So someone is asking herself, so should I go to take mammography at this point? Okay, so that depends. There are two groups of people who have the high risk group and the low risk group. The low risk group is those who do not have family relatives who have maybe they don't have family relatives who had the breast cancers or breast malignancy. Like no one in the first degree relative had had the breast cancers. Okay, so for the low risk group, they are not supposed to take mammography before the age of 40. So before 40, you are not advised to do mammography. But those who are high risk, like you have a family history of malignance of breast cancers, or you have the genes for the malignant changes of the breast, so you are supposed to take it as early as 30 years of age, and then you be screened yearly, every year. So but in low risk group, you're not supposed to take before you turn 40. And why does the age matters here? It matters because the density of the breast decreases with age. The density of the breast decreases with age. You in your 20s, your breast is more denser than a person who is 40 years of age. Why do we have this change in density? Because we know after menopause, or later in life, the glandular tissue is being replaced by fat tissue. But we know the fatty tissue appears a little bit darker on X-ray as compared to the fibrous tissue. The fibrous tissue, the glandular tissue. So the glandular tissue, they appear whiter, and the fat, they appear darker. This is why you have change in density with age. So as you age, the breast density goes down. And so what? How does this density affect the accuracy of mammography? Okay, it will affect because the dense breast tissue, for example, this is the dense breast, this is not dense breast. So this is the dense, this is a little bit less denser than this one. Okay, because the dense breast appears white on mammography. Okay, so what? Okay, it affects because the cancer tissues, the tumor tissues, the tissue also, they appear white on mammography. All right, now we know. Okay, so if you are in your 20s, you are going to do mammography. Your breast is normally appears white, but if you also have a cancer tissues, a tumor, they also appear white. So this is to say the diagnosis, the accuracy of diagnosis will be low. Why? Because you might have a tumor, but because your breast is white and the tumor is white, someone can miss the tumor. Correct? Yes. And then the other way is also true. The vice versa is true, because you might be labeled to have the breast tumor, which is actually not the tumor. It's a normal breast tissue. Why? Because they all appear white. So the breast tissue, the normal breast tissue, your normal breast tissue is white, and the tumor is also white before the age of 40. Why? Because of the density decreases with age. So if you do it above 40 years of age, it will be more accurate. It will be more accurate because we have the breast is majorly made by fat, and the fat is less denser, so we can pick the whitish tumor, which is white, on mammography. Okay, so before the age of 40, if you want to screen for the malignancies, the breast malignancy, you have to opt something else other than mammography. So you can do MRI or some other ultrasound and some other what diagnostic tests. Guys, I think I've made myself clear on that. You'll be asking the clinical, of course, when you are going to surgery, you're rotating, and in I don't know in which department, in which sub-unit of the department, but you might be asked, if you get this question, if you get the breast case in exam, you will be asked about mammography and the age. Okay, so those who have high risk of malignance, have high risk of breast malignance, they might opt to remove their breast so as to reduce the future risk of developing breast cancer. You might know Angela Jolie. So she's a Hollywood actress, and this girl over here, she did prophylactic mastectomy. She removed her breast in the year 2013 because she had high risk. She was a high risky group because she had the BRCA gene. She had the genes for breast cancer, which was guaranteeing the risk of developing breast cancer in the future. So she opted to take the breast out, to chop them off, and then that is what we call the surgical the prophylactic mastectomy. She also went further to take out the ovaries because of these genes. She was also exposed to the risk of ovarian cancers, so she also chose to chop the ovaries out. Okay, so for the high risky group, they can do prophylactic mastectomy, which is surgical removal of the breast to prevent the future development of the breast cancer. Okay, so we have congenital anomalies of the breast. We have the congenital anomalies of the breast. And so we have amastia, guys. Every time you see a means without or absence. So amastia means absence of mastia of the breast. So this is a complete absence of the breast tissue, including the nipple and areola. Complete absence of the breast tissue, including nipple and areola. But we have amasia without, so absence of breast tissue, but the nipple and the areola, they are present. Nipple and areola, for something like this, like there's no breast tissue, like there are no the glands, no, the glands are not there, but the nipple and areola are present. The nipple areola complex is present. We have atheria without theria. So this is the absence of nipple. The nipple areola complex fails to form, but the breast tissue might be there. Okay, the breast tissue might be there. And then we have polymastia. Poly means many, mastia breast. So this condition is also known as the supernumerary breast, or it can also call the accessory breast. So the breast might form along the nipple line. So we have a nipple line somewhere here, like this one. So someone might have an accessory breast, but it behaves like almost the same as the normal breast, because the changes that occur during menstruation, they occur also here. But it can also produce milk. If that is not enough, they can also produce milk. But this breast can also undergo changes like breast cancer. So the breast cancer can also happen in this supernumerary breast. And then lastly, we have the polytheria. Poly means many, theria and the nipple. So we have more than one nipple, which they happen on the nipple lines. They have the nipple lines, and this is the most common congenital anomalies of the breast. So of all the congenital anomalies, this is the most common one. If you know, like the dog has got also the nipple line, like the dogs have multiple breasts, so they have the line, so same line like this one. So it occurs in the same fashion. Okay, and then we have the gynecomastia. The gynecomastia is when a male is the benign enlargement of the male breast glandular tissue. I want you to bold the word glandular, because you said the breast is made up of two kinds of tissues. What are they? So we have the breast tissue and the fatty tissue. The breast tissue and the breast is glandular tissue. The glandular tissue and the fat tissue. So when the glandular tissue expands, like enlarges in male, we call it the gynecomastia. But when the fatty tissue enlarges, it is not a true gynecomastia. It's not a true gynecomastia. It's known as the pseudo gynecomastia. Like this can happen in people like obese people, like they have the breast, like they mimic the breast, something like gynecomastia, but it's not really the glandular tissue that is enlarged, but the fatty tissue, and that is not a true gynecomastia. Okay, so in what situations, and even there's a difference between the clinical difference between the real gynecomastia, like the true gynecomastia with the glandular tissue, and the pseudogynecomastia in obese people. For example, the real gynecomastia, if you palpate them, they feel like a disc, and they are tender, they are painful to touch. They are painful to touch. But for the normal, the pseudogynecomastia, those in obese people, like the fat part, it is a fat part, so it feels soft. It feels soft on palpation. When you palpate, it's soft, but it is also non-tender. It's not tender. It's soft, non-tender, and it's almost all over. But the gynecomastia is hard, little bit hard, disc-like in a circular fashion, and tender. So these are the difference between the two. But why would the man develop gynecomastia? Why would the man develop breast in the first place? Okay, so this is due to imbalance between the two hormones. We have the estrogen and the androgens, and the estrogens are not limited to females. Male also we have estrogen, but it is that balance between the estrogen and androgen that brings the certain pattern of development. So we're supposed to have a little high amount of estrogen, high amount of androgen as compared to estrogen, But in a situation in which the estrogen is higher, or the balance is distorted, someone can develop the breast tissue, the glandular breast tissue, which is what we call the gynecomastia. But why do people with liver failure they develop gynecomastia? Because you see, the gynecomastia is considered as a liver stigmata. Like if you find someone is a man with breast like this, like really glandular, not the pseudo breast, the really gynecomastia. The gynecomastia, it raises the suspicion of suspicion of liver failure. This is why it is considered as one of the liver stigmata. Why? Because the liver is breaking down the estrogen from active into less active form. So if you have a liver damage, if you have a liver failure, the level of estrogen will continue to be high in the circulating blood, and so it goes to the breast, and so the estrogen in the breast, they result in the development of breast, and so we have the gynecomastia, and this is what happens in people with the liver failure or liver diseases, liver cirrhosis, and some other forms of the liver failure. Okay, guys, for ladies, it is completely acceptable. It's completely acceptable if you have a certain degree of asymmetry between your breasts. Like if your breasts are not perfect, like equal in terms of structure, that is okay. Like in terms of weight and all that, but slightly difference is acceptable. The two breasts are not really like perfect, equal to one another. But as we've seen, there is no any muscle within the breast. There is no any muscle. It's just the tissue. We have the fatty and the glandular tissue and the ligaments. No muscles. The muscle from the base of the breast, which is actually not in the breast tissue. But men can also develop breast cancer. Why? Because men have also got breast tissue and the ducts. Same applies to those of women, but they are limited to men, because we know that the function of the breast is to produce milk, and we don't produce milk, so they are almost rudimentary. But we can also develop breast cancer. In fact, if you take 100 people with breast cancer, 99% of them will be female, but one of them will be a man. So the risk of developing cancer in man versus female, men versus women, is 1%. So it's not like all the time you find just women with breast cancer. No. And lastly, men have everything they need to produce milk but estrogen. So the only missing component is estrogen. So if you're subjected to a good amount of estrogen, then why not? You can very well develop. We can very well produce. You can very well produce milk. Alright, guys, as I've told you, the good and important, a great way of keeping in touch is subscribing, because you'll be notified once we release the new video. But in case you have additional question or comment, you can always put your thoughts downside in the comment section down below, and then we'll have in case you need to communicate, you can always write an email. But we have the Instagram and TikTok and the Neurosketch. Yeah, make sure you swing by there. And thank you for watching. See you next time. Until next time, stay curious.